Joining me now is Dr. Jennifer Bunch. She is a pain management specialist, but she works with Tampa Bay orthopedic specialists. So it kind of gets a little confusing when we're talking about orthopedic docs, pain management. You're technically an anesthesiologist.
Correct.
Who specializes in pain, which goes along with orthopedics pretty well. So I think it's a hand-in-hand piece. We're going to talk about things that people have a lot of, pain, but also how we treat it, which is not great, but there's new things coming out. So I think it's important that we, one, go backwards and look at all the issues that we've had with pain in the past. It would be bad for us not to make the statements of the pill mills that we had here, the narcotic problems we've had here, and a lot of it based on people who have real pain, but they don't treat it appropriately. So why don't we get that out of the way real quick, and then we'll talk about this new procedure.
Right, so chronic pain is different than acute pain in that acute pain would be someone who has an injury such as rolling an ankle, sprained ankle, they rest, it heals, they get better. Chronic pain lasts longer, and a person can oftentimes stop moving as much and they lose strength and flexibility and become worse over time. And the pain is no longer protective. It's not a warning sign of injury. It can cause debilitation instead. And treating chronic pain with medications like morphine, also called narcotics, those drugs just affect the brain and not make the person care about the pain. It doesn't really target or treat what's causing the pain.
So when we look at people with chronic pain, you just said they slow down, they sit down. If we give them a narcotic, it makes us slow down and sit down too, so we've compounded the problem instead of made the problem better.
Right.
And the bad part about narcotics is no matter how good you are with them, you're going to get tolerance. Tolerance leads to more and more medications, more and more side effects. So, excuse me, as we go through these things, we look at the least problematic things for our patients, the things that are cleanest for them, that help them and give us the same outcome. When we look at this new piece, it's called Coolief. It's a cooled RF, and it goes towards the areas where the nerves are. And its goal is to make those nerves stop screaming. It's probably about the easiest way to do it. So let's talk about this procedure and why it's different than the other procedures.
Right. So this procedure targets the nerve specifically that's responsible for the pain. And the nerves that I go after affect sensory or just the feelings of pain, and they don't affect the muscles. So patients don't lose strength or movement, which is very important. So radiofrequency ablation is a procedure that causes the painful nerve to die back just a tiny bit, about 2 to 3 millimeters. In traditional radiofrequency ablation, we create a small lesion to treat neck pain, back pain, and so forth. With this newer technology, we're able to make a larger lesion to treat knee pain, shoulder pain, hip pain, as well as the back pain and neck pain. We're able to make a larger lesion with this technology because there's a heat sink of water in the probe. So as the probe heats up, the water passes some of the heat out. And so we can make a larger area to affect the nerve than we could with the older technology. The reason why this is important is because not everyone's nerve runs along the exact same path. Many of the nerves I can see, such as in the hip, in the shoulder, and the knee, but as far as the back and some of the deeper nerves, I use bones which lead me to where the nerve usually runs, but as we know, everybody's a little bit different.
Which is a good thing and a bad thing. People also respond differently. I know the studies are out there saying that these individuals have done great things, and you gave me some dates or times of how long we can expect this therapy to work. Someone with a knee problem, you said up to 2 years of pain relief. Variations in that, what would cause it to work better, what would cause it to work less?
Right, so the studies showed about 24 months of pain reduction. Younger people have nerves that grow back faster than the elderly, for example. So they would be less likely to have 24 months of pain reduction.
Okay.
And as far as the knee treatment specifically, this kind of procedure is helpful for people who have already had a knee replacement surgery or who want to have a knee replacement surgery, and this procedure helps with post-operative pain as well.
Gotcha.
So, and of course, this is not a magic wand to fix things. Neither are pills. For pain management, it requires more than one pill or one injection. It requires a comprehensive approach. So this sort of injection procedure helps patients do more gentle stretching and exercises at home.
Keeps them active, which is what the biggest problem is with chronic pain.
Right.
Now, as an anesthesiologist, we know that you like sharp objects and put things in different places, and so a lot of people are concerned about the treatment hurting as much as the disease itself. When we talk about chronic pain, If you have a short-term amount of pain that gets rid of the long-term pain, it's really worth the time for that stuff. So when we look at these ultrasound-targeted pieces where you can go in and see the nerve, you minimize the collateral damage that could be out there, and the patients have less problems, have less complications, and get back to doing things faster, right?
Right. So prior to doing the radiofrequency treatment, in my clinic I use ultrasound and use numbing medicine, which is a local anesthetic, to numb up the nerve. And they go home, they walk, they do their regular activities, things that typically make their pain worse, and they report back to me if they were significantly better and if they were able to do those activities that are important to them. If the test procedure with just the numbing medicine makes them better, then I do the radiofrequency ablation. So at first they only have a test procedure. And as far as the pain of the procedure, I use numbing medicine called local anesthetic to numb up the skin and numb up the nerve as well so that they don't suffer during the procedure.
Yeah, a lot of people, it's really just the thought of getting a needle. It's not so much the other parts. I have lots of experience with that one where I actually have to blind people in order to make it so I can give them their shot that took a second to do. How quick does the symptoms go away with this treatment?
So for the test procedure, it's about 2 minutes for the local anesthetic to work. For the radiofrequency treatment, however, many patients notice an improvement within the first couple of weeks. However, for the full impact, it takes about 4 to 6 weeks.
Gotcha. And that's important to know because when we tell patients you're going to feel better with this and they don't, then they start disbelieving, they go back into old habits, they start taking their pain medicines, they lose the ability to get the benefits from a treatment like this. Now, this is not new, but it's new because of the heat sink portion of it in it. The ability is to have individuals like you who have special training in putting the medicines in the right place, can avoid your other guys, because they're orthopedic specialists, they're going to take things out and do surgery, which in pain management doesn't really help as much, sometimes causes as much pain as the underlying piece. So this is an alternative, but it's not the only thing that you do.
It's not the only thing, exactly. So some people wouldn't want to have a knee replacement. For example, if they have a lot of other serious medical problems that would make it dangerous for them to have a surgery, then this procedure could help them. Or people who've already had that surgery done, this could help reduce their pain. Because as we know, surgery can mechanically fix the knee or the back so that the bones and the muscles all work properly, but people can still have significant pain afterwards.
Right, and that makes them unhappy with their treatment, but also the outcomes change because if they have pain, doesn't matter how good it works, they won't use it, and it has to be used in order for it to work.
Right, everything could go very well in surgery and people still have pain, and so my goal is to help reduce my patients' pain so that they can be more active and do the things that are important to them.
Yeah, and you take a really tough field. I mean, pain management is really, really tough. I applaud you for taking it. I run from it myself. This is just another piece of the tool that you have to make people feel better every day. Underlying the disease doesn't go away. You're just helping them with the pain portion of it. So seeing their doctor, individual treatment is very important. Take into account those comorbid issues, and then hopefully it works for them. So. Great information. Thanks for joining us today. A lot of stuff that we could talk about. Unfortunately, we don't have the time for it, but I think if they call you up and talk about this, they might find us right for them.
All right. Well, it's very good to be here. Thank you for having me.